All right. Well, thank you very much for having me. I'm a late-minute substitute for Matt Nodowidgo, who had a scheduling conflict, so you guys have lost out. Matt's actually up in Evanston giving a talk while I'm down here. Thank you very much for having me. So we're going to talk a little bit about, or I'm going to talk a little bit about the idea of the tight connection between employment and health insurance and what that's doing for labor market outcomes. And in particular, what we're thinking about a lot is the rollout of the Affordable Care Act or Obamacare, whatever moniker you want to use, and how that might change people's attachment to the labor force going forward. So the United States is unique among industrialized countries in connecting employment so tightly with health insurance. Now, Matt, Tal, and I have used this phrase a lot, and it gets misinterpreted sometimes. We don't mean that as a positive thing. It's just a statement of fact, right? We're one of the few countries in the developed world in which really to get an actuarially fair price on insurance for many people, you need to be able to purchase in the group market, and those groups tend to be tied to employment. This is primarily a historical accident resulting from wage controls around World War II, but you can't say that the 6-decade dominance of this system is only a historical accident. There are some real benefits in the current structure for having it through your insurance through your employer. So at a minimum, it helps deal with some adverse selection issues by having this through the group market. It's also an untaxed form of compensation. So there are real reasons why you might want to get your insurance from your employer. As a result, in 2011, approximately 90% of privately insured Americans were getting their insurance from their employer or their spouse's employer through some private employer. So what we see then is that we see a real lack of, non-employer-related private health insurance options. In most states, public insurance can be limited to specific categorical groups. In the individual markets, it's actually very hard to get insurance, so there's not a ton of good work on the individual market. I think we'll see more of it going forward now that we see more of the individual market emerging. But for lack of data, we just don't know a lot about what goes on. But Nathaniel Hendren does have his job market paper, which shows really high denial rates in this market for people who have any sort of pre-existing condition. So if you're over 40 and you've gone to the doctor once, it's going to be much more difficult for you to ever get insurance in that market. What we do in this paper is we examine the labor supply effects of a change in the non-employer option in health insurance. And so somewhat a surprise to me, in 1994, Tennessee was really at the vanguard of health insurance reform in the United States. In some ways, this was thought to be sort of what was going to be the prelude to the original sort of President Clinton's Hillary Care initiative, and Tennessee sort of was out in front. Hillary Care never happened, and they were sort of out on their own. And what they did is they did two things. They moved all of their normal, what we refer to as categorically eligible people for health insurance, or for public health insurance for Medicaid. This is the exceptionally poor with families, children, and those who are disabled. They put them all in Medicaid managed care. And they said, okay, we're going to get lots of savings from this that may or may not emerge, it turns out. And we'll do that to cover a large expansion of what was referred to as the uninsured and uninsurable population. So these are people who didn't have insurance before the law was passed or who could show that they had been denied access to insurance in the private market. All they had to do at this point was produce one letter that stated that they had been denied access to private insurance. And so importantly, what they're doing, though, is they're enrolling individuals regardless of their income level or categorical eligibility for traditional Medicaid. There aren't many states that have ever done this in history. New York would be one other example. So what are the savings from? From the benefits of Medicaid managed care. So I would be equally skeptical if what I tell your boys. I mean, they thought that they'd be able to get savings by privatizing this, putting it into a managed care setting that would reduce the network. And then they spent that money. It's part of the waiver process, is these have to be budget neutral. So you can book some savings that are going to happen in the future, even if they don't end up being real savings. Importantly, for what's going to be our identification strategy, when people reflect back on this, they say that the important thing here is that it changes the idea of public health insurance, especially by bringing in childless adults who historically have never been eligible for Medicaid. And we're going to concentrate a lot on those individuals, partially because we can get some traction identification, but also this is the group really that's going to be affected the most by the Affordable Care Act. People who are relatively low income and don't have access to health insurance. So what happens, partially because we don't have the savings, is that Tennessee runs out of money about 10 years later. In many ways, they accidentally create a high-risk pool for insurance, right? You're creating an insurance pool only for people who the private sector won't give insurance to. And they decide to end the program rather suddenly. So there was some debate over the year before, but in a 3-month period, they disenroll 170,000 people from public health insurance. And so we're going to look what happens to those individuals, partially because we haven't seen such a large disenrollment before. It's 4% of the non-elderly population. Be like 8+ million people nationwide. So it's a pretty substantial disenrollment. The people who lost coverage were non-disabled, childless adults with higher incomes than the traditional population. That's really the group of people who lose coverage in this setting. This is what it looks like if you just want to look in graphical form. It's all coming from this uninsured and uninsurable population, and it represents a large, permanent, and meaningful decrease in the generosity of public health insurance in Tennessee. So this wasn't a case where people were able to get on other programs for a variety of reasons. They really did remove these people directly from public health insurance. And in particular, non-disabled childless adults under 65 after the law could not get access to public health insurance in Tennessee, really regardless of what their income level was. This relates actually very closely to the Affordable Care Act that's passed in 2010 that's now sort of rolling out. Anyone who's paid a passing attention to the news can't help but see that lots of these things are going to start to come into effect now. This is the largest change to health insurance in the United States since the Great Society programs of the 1960s. We expect that about 25 million people will get new insurance as a result of this bill. Those of you who follow the CBO closely will see that number just keeps ticking down year after year. So we started at 32 million, we're down to 25 million. If every state were to enact the Medicaid expansion, that's also a point of debate, about 13 million of those people will get their insurance through public programs. And what's going to happen is we're going to raise eligibility to 140% of the poverty line, regardless of any categorical point. There are lots of similarities between TennCare and the ACA. In the interest of time, I won't spend too much time, but basically the structure is the same for all of them. Healthcare is free, no premium, up to a certain point, between 100 and 140% of the poverty line. And then your premiums sort of slowly increase with your income. So there is a marginal tax rate here as you earn more. And I know Casey's done a lot of work on this. Every possible cut of the marginal tax rate you could think about, there's a slow increase. But what there isn't is sort of a large Medicaid notch. So if you look at what the premiums would be under the ACA or under TennCare, if you were in 2004, they actually move relatively similarly. So it's not the case of if you cross the threshold out of Medicaid anymore, that all of a sudden you don't have access to health insurance or you see this huge change in your budget set. And that allows us to sort of, with this work, reconsider the role of what's often been called Medicaid notches. So when people have focused on the labor supply effects of public insurance in the past, they've really focused on this point, this very explicit work disincentive. Let's imagine a cutoff of $10,000. As soon as you were in 10,001, you lose access to a very valuable program. That's not really a case in federal health insurance anymore. It's gonna exist at 400% of the poverty line. There will be a notch up there, but that part of the distribution is a lot thinner than where these notches traditionally exist. We're going to exploit two fairly simple sources of variation. We're going to start with a very simple difference in difference estimate. We look at Tennessee compared to the rest of the states in the American South. You can have any permutation of control groups you want here. You can do the entire United States. You can do the East, North, Central. You can do some of the Abadi sort of synthetic control groups, and you end up getting the same results, primarily because most of the action is happening in Tennessee. This is where the treatment group is changing a lot. We're also going to be worried that there could be some shocks that are Tennessee-specific during this time period. So what we're going to do is we're going to compare the outcomes of childless adults in Tennessee to their non-childless counterparts, and then also do that across all states in a triple difference specification. So if we think there's some particular shock to Tennessee here, we're not going to have bias from unless that shock is very particular to people without children in Tennessee compared to people with children in Tennessee. And we're going to start in the paper and sort of letting the data in many ways speak for itself. I know people have talked about that a lot today, but showing it sort of in just simple graphical formats to start. We have a CPS sample, it's 21 to 64, 2000 to 2007, those with a college degree or less. So if you look at public coverage, right, what we see here is Tennessee versus other southern states. They're going along roughly the same. We can sort of argue about whether that's the same pre-trend, but you can do this across a bunch of different control groups. Then there's this large shock to public health insurance in Tennessee. This we should expect to see. We know 4% of people lost public health insurance. We see 4% in the CPS. It's a good sort of first check. But then we can disaggregate these groups by whether you have kids or not. People in Tennessee and people in the rest of the South. So you can look at this blue line at the top, which is just that Tennessee line broken up by childless adult status, and the dashed line at the bottom are all other southern states broken up by whether you have children or not. And what you see is all of the actions happening here among people in Tennessee who don't have children. The group we know was most affected by the disenrollment. Again, that's just share in public coverage. That's particularly interesting to like my health services colleagues, right? But here we're at a labor conference. Let's think a little bit more broadly about the effects of this. Let's look at share employed. What we see again, looking at Tennessee, is that these again are following relatively similar time trends, and then we see this increase in share employed among people in Tennessee, an idea of people moving into the labor market. And again, we can see that that's primarily happening among individuals who are in Tennessee who have no children. That's where this big increase is happening. Again, the people who are most affected by this change in public health insurance status. We can look at this in a graphical format. We see about in the difference estimate, in a regression format, 4.6 percentage points change. You look at the triple difference, again, that's larger as we would expect, right? These are people who we know were more affected by the drop in public health insurance. And we can look at share employed. And what we see is that it's about half the people who lose access to public health insurance move into the labor market as a result of this change. So we can start to get a sense. Oh, the other thing, this is related to the comments we had earlier, we do have relatively small samples here, right? We are looking at Tennessee, other states, year by year. You might be worried this is just sort of a problem with sort of sampling error. So let's take a look in the sort of a permutation test way of every 2-year change among states in our sample over the time period we're talking about 2000 to 2011. What we see is that every other state, there's sort of this nice normal distribution of changes, but for share public health insurance, Tennessee is all the way here in the tail. And then walking to this side, right, for the increase in employment, Tennessee is over here as well. So it doesn't appear that this is driven just by small sample concerns within the CPS. How quickly did the change occur? So one thing we might be interested to think about is the idea that it's not, these people were able to move into the labor market, but there are some costs if you suffer a gap in insurance or a gap in coverage that we actually do think are meaningful to people's welfare, but also their health status. Let's see how fast it occurs. We can look at the local area unemployment statistics data. What we see is that it's really remarkably quickly after the disenrollment, we start to see this increase in employment where people are moving into the labor force, which we'll argue in a minute is going to be because they're looking for access to private health insurance. But we do see this immediate tick up in these data. We also look at the idea of search behavior. So you can look at Google Trends. This is like a very popular thing to do now about what people have done for their change in job search behavior. Even in 2005 in Tennessee, which I was a little skeptical as to whether this would be a primary way that the low-income population would look for jobs. You do see, if you look at the phrase job openings in Tennessee, that there's a local maximum in this series among the two months around when Tennessee does a disenrollment. You can run the same thing we do in the paper for the phrase TennCare. You get roughly the same pattern. There's this big spike in the time period in which Tennessee is doing this rather massive disenrollment. So one question, we can talk about sort of how big is this labor supply increase? So this is a question we spent a lot of time thinking about. Is this too big? It's always tough with empirical work. One thing you can think about is so what would be the change in wages that you need to experience to see a similar change in extensive margin labor supply. Raj Chetty and co-authors have the survey of the literature where they see the mean extensive margin labor supply is 0.25. If you look at our triple difference estimate, that's a 6.5% increase in employment. This implies that you would need a 26.2% wage increase to cause the same increase in extensive margin labor supply. We're looking at people primarily in our data that are around 100 to 200% of the federal poverty line. In 2004, that means you would be seeing a wage change of about $2,400 to $4,900. In this time period, the average price of employer-provided health insurance is about $3,700. So this just gives a sense we're not wildly off in terms of the value of health insurance here. This obviously number has grown quite a bit since 2004, the average price of employer-provided health insurance. So are the observed employment changes consistent with a search for health insurance? So I think we provide pretty compelling evidence that there is this large labor supply increase immediately following the disenrollment. If it is caused by a search for health insurance, we should expect it to manifest itself within certain groups. So for example, let's look at it by hours, right? We know that if you look at like the National Health Interview Survey, if you work more hours, you're more likely to be offered employment from your employer. And that 20 hours is a pretty big notch in terms of your probability of getting an offer of health insurance. 35 is the next big one after that. But as I'll show you, there's lots of places where if you work 20 hours, you can get access to health insurance from your employer. And so if we look by hours, we see that the employed result is almost entirely among people that are employed more than 20 hours at their job. So again, that's comforting. That would be the pattern we would expect if this is people looking for health insurance. You can also look, are you employed with private health insurance? Again, I think it's a vast majority, I think it's over 90% of the increase is coming among people who are employed with private health insurance from an employer. We don't know if it's their employer in the CPS, but from an employer. So again, this appears to be a search for private health insurance. In terms of can you get a job at 20 hours, so you can Google 20 best part-time jobs with benefits. Any of these firms, if you work more than 20 hours, will give you private health insurance. Starbucks perhaps being the most famous. As I grew up, everyone who had that dream of being an actor outside New York City had a similar dream of being a barista for some part of their life, apparently. And so they really showed up a lot in Starbucks. And so these are all jobs where you could get that. And these are not jobs that sort of we were thinking of are very high in the skill distribution. I'm not trying to be in the pejorative sense, but not in a way in which these would not be attainable to people in this setting. We can also say, should there be a change in private health insurance coverage, and how fast should that change occur? Again, given what we saw with the local area unemployment statistics, we should expect that the change in health insurance should be relatively swift as well. We might be interested in the dynamics of that. The problem is the CPS doesn't provide monthly information on insurance status. We only have insurance status at the annual basis, but we can look at the behavioral risk factor surveillance system that does have monthly data. The trade-off for monthly data in this setting is really horrible questions about insurance. In fact, I shouldn't say questions. There's one question about insurance. Do you have it? That's it. So I can give you sort of the net effect of our response for public and private health insurance. And what we see is that there's obviously a big drop in the percent insured in Tennessee compared to all southern states right when the disenrollment happens, but a relatively swift climb back up that starts to mirror the change that we saw in the local area unemployment statistics, giving us, again, some idea that what's happening here is just people are moving into the market to get private health insurance. You might expect also there's some heterogeneity here. So labor and crowd-out responses should be a function of your valuation of health insurance and your ability to gain coverage in the private market. You might think that groups that then have a high valuation of insurance would see a larger labor supply response and a greater increase of being employed with private health insurance. And accordingly, we do find our largest labor supply responses for older workers and sicker workers. And so particularly the older workers is an interesting point. These are people 40 to 64. So I'd like to even cut this finer. We just don't have enough data to support it. But it's not hard to imagine who these people might be. You're between, let's say, 60 and 65. You'd like to retire. You can't. Because you can't get access to some type of retiree health coverage. Very few firms now offer retiree health coverage. TennCare might have been a way for you to do that. When they take it away, you move back into the labor force at an hour's point in which you can get access to health insurance. So one thing we can do is extrapolate this to the ACA. And so this becomes a dangerous exercise, and this is the place where people, we had the most discussion with people in Washington and other places. So you want to find a population in Tennessee that's relatively similar to people who are going to be affected by the ACA. And we try and be very conservative with this. And so we say is, listen, let's look at people who have less than 200% of the poverty, who are earning less than 200% of the poverty line, who are working and have access to insurance from their employer. That's a group who fits our income demographics pretty well. Who has an expressed desire for health insurance because they are getting it from their employer and they're either trading off wages or explicit costs in terms of their premiums. And let's see what would happen if we apply our labor supply estimates to them. What we find is that there are about 840,000 to 1.5 million people who are childless adults, less than 200% of the poverty line, who have employer-provided coverage but but also not currently eligible for public health insurance. If you look at those individuals and we apply our estimates, we think anywhere from 530 to 950,000 people would leave the labor force as a result of the ACA. That's about 0.3 to 0.6 percentage points of aggregate labor supply. For many reasons, you might think this could be a lower bound estimate because there's clearly going to be changes above 200% of the poverty line. I just don't think that we have the confidence to sort of apply outside of our group to that point because people who earn more than 200% of the poverty line are probably going to react a little bit differently to the decision to work or not. So one question is, what are these people doing? This is actually the question I get often, right? Particularly with the phrase "these people" often. So it's unclear what they're doing. We do find our strongest evidence for older workers. So this could just be that this is going to be a form of early retirement, all right? You can't get onto Medicare until you're 65. You don't have retiree health insurance. 26% of employers offer retiree health insurance now. You're using this as early retirement. We can question whether that's a good or a bad thing. Nothing we say in the paper is really a normative statement. We're not talking about whether this is good or bad. I think there's future work to determine that. It could be that those who are affected just really have a strong disutility from work. They could have preference for leisure. We also find large responses for those in poor health. Finus's work, his 1999 Eli lecture, talks also that if you're not working, it's not like your income goes to zero. Right? This is a very interesting paper that talks about that your wages are not abysmally low, is the phrase that he uses. So we shouldn't think that sort of the decision to not work here means you move into absolute destitution. There are certainly both unearned income sources and also government programs you would be eligible for. And so it might be that when you're not working, you're just okay with this level of income, conditional that you get access to health insurance. That's sort of the thing that you need to have. So what do we find? We find that the TennCare disenrollment led to a sharp rise in employment in private coverage. What this suggests is substantial employment lock in the United States economy. And we sort of use that term employment lock to separate it from the idea of job lock, just that we're not thinking about as much about job mobility here, though that's definitely, I think, going to be something that matters. We're thinking about this more about purely the extensive margin labor supply response. We find a lot of this is going to be for what I think looks like retiree-type health coverage, though we would imagine that there's also going to be effects here on whether people can move into either small businesses or entrepreneurial ventures. I'm sure it's true here at Booth as much as Kellogg that every student's going to start their startup when they leave. 90% of my students are going to sort of change the world with their startup. Now they can do that and get access to health insurance. And I've actually had students come talk to me about this and want to know more about the exchanges for that reason, because they have families and they want to do that. So there might be some benefits here as well. There's also a point here that that this can inform theoretical models of optimal public health insurance generosity. So Raj, Chetty, and Sayas have looked at the Bailey model again. This endogenous labor supply is a response you might want to put in there. We're doing some other work on uncompensated care as well, which is something else you might want to put in there, given that sort of healthcare is the one good where if we change the social insurance program, private people still have to provide you with the good. We don't see that we cut the food stamps by $5 billion. There's no expectation that Jewel is going to keep giving food to people just because their food stamp benefits have gone down, but that's fundamentally different in the hospital sector. And so we want to think about ways in which that's going to sort of inform our models of what optimal social health insurance should be. Okay, so 1125. I don't have the stature to go over, so. Thank you.
Like the others, I'm really pleased to be here to honor Finest. Finest offered me a job way back a long time ago with the Graduate Center at City University, and Jim Smith he offered a job to at the same time. He did more work with Jim, I think, did with me later on. He changed certainly my career trajectory a lot. I was basically a liberal arts guy at that time, and I went into sort of the research thing. And on another occasion, Kevin pointed out that I and others like me, including pretty much everyone in this room, have expressed their gratitude to Finest for what he's done for them by regularly contributing their license fees for the state. And I've been doing this, but it does give me an occasion to actually do this for free, so it's kind of like a free lunch. This paper is kind of a discussor's nightmare because it's really an excellent paper. It's making use of a really important, I think, interesting large-scale natural experiment on an important topic. The effects are relatively understood in terms of simple economic theory, so there's not many times natural experiments or even unnatural experiments are ones where it's really complicated to figure out exactly who got the treatment, who didn't, all kinds of issues about selection and so on and so forth. And most of these are really missing. These complications are missing here in terms of this one. It was a particular group of guys that got access to public health insurance, and then that particular group that got disenrolled later on. The clean econometrics methodology really is a consequence of that. And in terms of the bolded point here is I think the experiment can shed light on other important topics, and I'll talk about that briefly a little bit later. But in addition to the kind of positive economic side of this, much additional interest is because of the implications for the American Affordable Care Act policy. But I think the implication that the ACA may cause a substantial decrease in the employment of those not currently covered by insurance may be misleading, and I'll talk a little bit more about that in my comments. So the main results, just to quickly review them, is the loss of public health insurance for childless Medicaid enrollees caused a substantial labor supply shock in Tennessee. That's been shown really quite nicely in the paper. Outward shift in labor supply for full-time jobs that are eligible for employer-provided health insurance. suggests, confirms the idea that it's really those who are seeking health insurance who increase their participation in the labor market. There's a large reduction in public Medicaid coverage, which was partially offset by increased employment and private insurance coverage. The crowd-out estimates was something like between 35 and 47% decrease in the ratio of public insurance to private insurance that occurred, decreased occurred during that period. Employment effects were largest for older workers who are likely to value health insurance most highly. And given outside estimates of the labor force participation wage elasticity, the magnitude of effect on participation of loss at TennCare is equivalent to about a 26% wage decrease, or between $1,800 to $4,900 in the cost of a health insurance willingness to pay for a health insurance policy is sort of what they found. Now, I wanted to just say that there's some additional possible uses of TennCare experiment for other topics. The labor supply experience and health insurance coverage of the experimental population really, for the most part, ran through 2007 in the paper. It would be interesting to see, it seems to me, that whether the endogenously pushing people into employment before 2008 helped them cope with recession. Paper shows there was an increase in disability claims of this group, and that's not too surprising. These were people who previously were on public health insurance, and those who didn't get employed, probably their alternative route to both insurance and income would have been through disability. But it would be interesting to know for those who did get employed, what happened? Was there a boost to employment have a positive effect on their human capital? Were those connections to work useful and so forth? I think this body of data could shed light on that kind of question that's often very difficult to get out with other kinds of data. The paper focuses on the policy relevance of the TennCare experience on the ACA. And they argue that the TennCare reduction is basically like ACA run in reverse. The TennCare took a group of people who were on public health insurance and took it away from them, and look at what happened. Here what you're seeing is that the ACA will take a group of people who don't have insurance and put them on it. So the question is sort of this kind of question about symmetry. There's also a question about exactly how the situation with the TennCare experiment corresponds to the situation that we have with ACA, and I'm going to try to argue that the correspondence is not quite as large as it seems on the surface. So I believe that this sort of labor. So what's done in the TennCare case, and it's ended quite ably, is that TennCare really had an effect on shock labor supply, but it didn't have any shock on labor demand. Nothing about the TennCare disenrollment that would have influenced labor demand, and I think that's correct. However, but I believe this will not be the case in the ACA if employers of low-skilled labor should employer-provided insurance. I'll sort of first make an argument why I think that's likely to be the case. And say if that is the case, what's going to be the effect, and then I'm going to argue that there's an effect on labor demand for very sort of simple theoretical reasons. If the employers do shift, the demand for these workers will rise by the opportunity cost of the labor that they're the insurance that they're no longer be offering, and the change in demand will offset, at least in part, the reduction in labor supply caused by the Medicaid expansion. Why ACA may cause first shed private coverage for low-skilled workers. Low-wage workers gain virtually no tax benefit from employer-provided insurance. There's a public alternative. Firms have little incentive to provide private insurance to low-wage workers, and indeed, many employers of low-wage workers have shed private insurance already, and the reason is pretty clear from an economic point of view. I'm really a low-wage guy. Health insurance is very expensive, and I have other things that I may want to spend money on. It's not worth it to me to take the wage cut. That would be the compensating variation for the cost of providing the health insurance. Employers see this, and their equilibrium in that situation is not to offer insurance. It's just too expensive for that class of worker. In addition, the ACA would allow more highly compensated, thank you, Sharon. ACA would allow more highly compensated workers to purchase more elaborate plans, thus allowing for variation in the quality of the plan for workers within a given firm. It's not possible under the rules that require the same plans be offered to workers within the firm from janitor to CEO. So you are likely to see an expansion, it seems to me, in the variation. Thus, many firms may find it advantageous to stop offering private insurance. And so I give a quick illustration, and I use the data that Craig briefly talked about in his presentation. Suppose there's a wage elasticity of 0.25. Suppose the labor supply shift due to TennCare disenrollment is 6.5%. Implied wage change to generate that change, they calculated is about 26%. For workers with wages at the poverty line, they would pay the 26% of their earnings is $2,400, which is the value of the insurance to the worker, and the cost of TennCare is average about $1,700. And you can sort of see in the equilibrium in the labor market before and after the ACA, with the before situation being the red dotted lines, and the after situation being this. The shift from in the supply curve is the numbers that I already showed you just when Craig went through this. There's an upward shift in demand. On the other hand, and that upward shift, according to these numbers, would be $2,400. The upward shift in the demand side, if firms are not offering insurance, this would be about $1,700 cost of the insurance. And so labor demand is increasing, not quite by as much as supply has shifted. And so the overall effect would be a small decrease in the labor force participation.
Well, you're arguing that private firms will stop providing insurance, and they'll allow workers to receive subsidized care, and that will increase the private firms' demand for labor because their costs will reduce. Where's the money going to come from?
From the general tax funds.
Right. So the workers are going to be taxed more heavily. Is it clear that their after-tax income is going to rise?
No, I don't know.
Yeah.
Say that.
I'm saying the workers are going to be taxed more heavily if tax rates go up to support the.
But remember that these guys are low-wage workers, and they're paying almost no taxes now, and probably won't pay any taxes later.
Also, they're getting a giant subsidy, too.
Pardon?
They're getting a giant subsidy if they get their insurance on, $10,000. So.
The idea is that the people not in this skill range are going to pay for it.
Yeah.
That I agree, yeah.
And they're the,
That certainly is going to happen.
so there the labor demand goes down. Right?
This all depend on your view of the labor market that started before, because what you're really saying is the tax rate that existed under TennCare was much greater than it looked. It's not the clawback that existed, because for a bunch of employers, you get this coverage that isn't worth it. You're already covered, so it's like your employer's cost is much higher than what you benefit. That was the old one. But if you thought there was compensating differential in the labor market, you wouldn't have seen that. Right? In some sense, your finding is kind of saying that there was this compensating differential, because
Well, but
There were firms out there who didn't provide insurance. If that was an equalizing difference, these guys would have wanted to go to those.
That's not Marshall.
Yeah, I mean, so part of it is that I think there's just the sort of $1,700 value sum up for TennCare. For some people, it was a good to have an infinite price. And that sort of floats out. You usually couldn't get access to it at all. So it's hard to think about the compensating differential in that setting.
Right, so you can have guys who are beyond that compensating. Exactly. And I agree, but I'm saying, I'm not sure you can go all the way to where Bob's going because of that problem is the issue, because guys who didn't want the insurance, there were other firms they could go to.
I mean, these guys, the guys in Tennessee were in a market in which most of the firms, or many of the firms were providing insurance.
Hello? I'm not sure that's.
I wouldn't say, I mean, I would say like it's 45.
There were many firms that were providing insurance, and the people who did in fact get jobs were the ones who apparently got, they show that they got insurance from private sources, so they went out and found jobs with firms that were offering.
But you gotta be careful too there, because then you're not counting the people who are actually going to be losing their job, because these are the people, by your group logic, they're the people who value insurance the most. They're probably the most costly people.
Yep.
And therefore, the employers are going to have to cut wages for everybody else because the mixed pool is going to get worse.
The other thing that's going on here, the thing is that this is the time of general economic expansion in Tennessee as well. That it's going to be very different potentially. We clear about the in 2010, where we're still waiting for our time here of general economic expansion. It's going to be a little bit less.
I'm just saying,
When was TennCare introduced?
It's introduced in '94, but cut in 2005.
Did you look at the introduction?
So the introduction is complicated. So then the childless adults don't have preferential access that Medicaid then. So you can't look at this cut by childless adult or not then. And also people sort of fade on, or sort of slowly dribble onto the program as opposed to getting cut at once, so the power is a problem as well. But you get sort of things that are suggestively how you would think you would look, but much less precision.
the trouble with this cost point is that the impact is on the other groups.
Yep.
You have to believe that.
Okay, it's a great paper, and congratulations to Finance on your 75th birthday, but yes, you really are older than I am.
That's just not true. I mean, there's many senses of age.
Which census did you have in mind?
I actually have two questions. One is, part of this is operating in the background of another distortion, which is that there's not a private, sort of an individual level healthcare market available for these guys in Tennessee, right? You would love to have the experiment where they could have bought on the private market what they ended up buying through employment, and to see whether they in fact would have, if they hadn't gotten a subsidy, whether they would have just bought privately or continued to work in that case. So you're not, it's a very big open question. That's just a central point. An empirical question is, did you try to look at if anyone was crowded out of employment by the movement of these guys in? Like, do we see teenagers and stuff leaving the types of jobs that people are entering as a result of the elimination of TennCare?
So that's a good point. We haven't looked expressly at that. We've looked at sort of in like this grouper and Sager kind of way, who the marginal industry was or the marginal employee. We just don't have the power to really do that. Thinking about whether it's sort of low-end teenagers that are losing their job is an interesting point. Low-end's not the right, sort of low-skilled teenagers. Yes, we can take a look at that.
I mean, it's just interesting to know what total employment grows, or...
So if you look at the local area, the Laos, it does look like total employment's going up as well. So probably not one for one, no. I'd have to imagine it's not one for one. And as you get further out, you have the problem that like this, there are aggregate demand issues when you're bringing the automakers into Tennessee in like 07.
Steve?
Yeah, I just had a question about the eligibility rule that maybe I didn't catch. How many people in the employment gains after the disenrollment got jobs that would have rendered them ineligible for TennCare?
So all of them would have, if they got a job where they were offered public or private health insurance, they would have been ineligible for their coverage to the extent they reported that to the relevant authority. And they were sort of not annual audits.
So how do you separate the employment gain being looking for a job to get health insurance versus looking for a job now that you can keep the wage that you get and your insurance when you have that job, where it's skewed would have lost your insurance beforehand, or you, like the benefit.
So again, I think I'm missing exactly, because beforehand, right, what these people could have done is gone to the 50% of jobs Kevin's talking about and had higher wages and then kept it. They would have, if they were working in a place that didn't offer health insurance, then they could have kept their TennCare. That's the issue. It's if they went to a place where they were offered, because they had to be uninsurable. So if you're getting an offer of private health insurance, so if they had preferences they wanted to work, they could have worked, gotten a higher wage because of the compensating differential, and gotten their public health insurance, and paid a very small increase in the premium.
Good. So maybe I missed you kind of ahead in your story. So kind of sympathetic to the argument that labor demand may adjust in different ways in terms of the decline in Tennessee versus the ACA. But it seems the main reason for that is the minimum wage, because these are a lot of guys along, either at or near the minimum wage. So when you're kind of increasing labor supply, you would think that have downward pressures on wages. In Tennessee, that downward pressure is going to be muted by the fact that eventually they're pressed against the minimum wage, and that's gonna give you a much bigger bang in terms of the employment effects compared to the ACA, where you're going to have upward wage pressures and there's no upward down.
That's a fair point. There's lots of reasons I think for about. So one thing I think in the paper we try and be more clear in the revised version too, that there's a loose connection between the ACA and this, but it gives us some information of, I wouldn't even call it a partial equilibrium effect, right? It's like a partial equilibrium. It's of one particular part of the ACA, right? The partial equilibrium effect of that one part, and there'll be these labor demand shocks as well.
This is just asymmetry.
Then there's a couple ways the asymmetry is going to matter as well. One is your story, which is the binding minimum wage. Though if you're a childless adult making 200% of the poverty line, then the minimum wage is $5.15 then. So you're doing, in terms of that, you're probably a little bit further than minimum wage than you might think. The other asymmetry is also just like the salience of the shock. So giving someone insurance is really probably not the same as taking it away. And so I don't want to have a large behavioral conversation about this, but we can think about sort of this as a point of salience or information. And so we might expect is that the effect for the ACA is going to be slower, as you sort of, it's going to happen, I think, through job churn. When you lose your job, you might not have the incentive to go get the next one. Not that the minute the ACA passes, you're throwing down your pencil, walking out of the Starbucks.
You don't need behavioral for that.
I know. So I'm saying you can get it. You can get
variables of any type.
Exactly. Yeah. So that's why I said we can avoid the behavioral conversation.
Did you take a look at the fertility response of those childless parents?
No, we did not. I mean, that is, and I should not shake my head like that. That is a good paper to write. It's not one that we have or we're planning on writing. But you could imagine, I mean, we haven't seen, in most of the literature, we haven't seen large responses in fertility to changes like this. So the EITC literature has been pretty, hasn't found substantially large effects here. But they might exist in this setting. It's just not something we looked at or we plan on looking at. We are looking at sort of changes in the most immediate questions, like changes in utilization of health service and your health, and also more importantly, the spillover to private sector firms. But it's fair game for anyone that wants to look at fertility, though. Given that we've given this paper a lot, and that comes up a lot, so there might be other people who are thinking about that question. But it's a good question. I just want to clarify one point from Bob's. We find a decrease in disability, not an increase. So
I thought you had a chart.
We do, and it's a dip down in Tennessee compared to the southern states.
But the general trend was this very rapid trend down.
After they recovered during the 08 recession, but this initial dip down, there's sort of two ways you can think about how disability should react to losing access to public health insurance. One is that you want to go on disability to get access to Medicare, but you do have a 2-year wait where you can't earn above substantial gainful activity, like $800 if you're non-blind in Tennessee at this point. And so that's a large gap if you have a high preference for health insurance. What we find is that it appears that the desire for health insurance might overwhelm that, and that is something we're trying to look at, is the effect of public health insurance on the take-up and utilization of other programs, but it is a decrease here, though theoretically it's ambiguous what kind of effect we should find.